Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting spine imaging case of the day. As always, I'd like to start out by letting you know that all of the educational content found within this presentation has been completely de-identified in order to protect patient privacy. So this is a patient who presented with chronic neck pain. And I've got three total images for you to look at. The image on the left is a sagittal non-contrast CT. The image in the middle is a sagittal T2 weighted image. And the image on the right is an axial T2 weighted image. So I'll give you all the surgical changes and the long segment myelomalacia of the cord. What else do you see going on here? And what's the underlying cause of this patient's problems, or at least the most likely cause of their problems? Okay, so let's start with the imaging. First up is our midline sagittal non-contrast CT image. This is done in bone algorithm. And what should become apparent is that we have the dens has become cranially displaced. So it extends more superiorly than it should, and it extends up into the foramen magnum. So you can see that denoted here with the yellow arrow. And if you look, we have this line that's drawn from the basion to the opistheon. It's named the McRae line, if you'd like to name things after people. And the dens should not extend above it like it does here. So this is abnormal cranial migration of the dens. Now, as you look at the occipital to cervical relationship, so C1 to the occiput or the C1 to the skull base, that alignment's maintained. The anterior and posterior arches are in their normal location. It just happens to be the dens that's migrating upward. The other thing that you'll notice here is in this patient who has what we call basilar invagination or cranial settling with that upward migration of the dens. The other thing that you'll notice is we have an abnormal appearance of the atlantoaxial joint itself. We can see that it's eroded, it's irregular, and we've got some narrowing of C1 and C2. So again, we have that upward migration, that cranial displacement of the dens into the foramen magnum, so-called basilar invagination or cranial settling. And then we also have an eroded and irregular appearance at C1, C2. As we look at our sagittal T2 weighted image, we again see that significant basilar invagination, denoted here by the yellow arrow and our McRae line. But you'll also notice that there's mass effect upon the ventral medulla, denoted here with the yellow arrow. This dens is literally thumbing the medulla, and that obviously can set the patient up to traumatic injury or compressive injury. Now, again, we have those post-surgical changes. This patient's been decompressed before. We also have that long segment myelomalacia. Again, I'll give you those findings. What I wanted you to take home from this was that basilar invagination finding. And then on our axial T2 weighted image, I'm showing you this because it nicely details two things that really shouldn't be on the same axial slice. So we have our dens, denoted here by the yellow arrow, and we also have our medulla. Ordinarily, the dens should not extend up so superior that we see it at the level of the medulla. And this patient has had this chronic upward migration of the dens for a long time, to the point that it's remodeling their posterior clivus due to this chronic impaction of it. And we can even see that there's this sclerotic change of the bone and sort of a troughed out appearance of the posterior clivus. So, what's the most likely diagnosis in this patient? What set them up for all of their abnormalities? Well, this is a case of rheumatoid arthritis, or RA. So RA is an autoimmune inflammatory arthritis that affects the joint synovium. And this is our prototypic seropositive spondyloarthropathy. These patients will have a positive rheumatoid factor whenever you check serologies. This is most commonly a disease of young adult women, most commonly presenting somewhere in their early 40s, and it's about 2.5 times more common in women than in men. In patients who have long-standing RA involving their cervical spine, a large percentage of them, maybe over 40%, will develop cervical spine subluxations. And that can lead to neurologic symptoms, and when that happens, that's a very poor prognostic sign for these patients. So what are the common spine manifestations of rheumatoid arthritis? Well, first of all, look for those erosions. Those are particularly seen at the dens as well as the facet and uncovertebral joints, because this is a joint-centric process. You'll look for that retrodental pannus. Now, one of the important things to keep in mind with RA, that's typically going to be non-calcified. And they may have atlantoaxial instability. This is a time whenever carefully supervised flexion and extension radiographs, or some people do flexion and extension MRI with rapid protocol sequences, this is a time that should be considered, because you want to figure out whether or not these patients have significant instability and potentially could have compressive issues of their cord or of their lower medulla, their cervicomedullary junction as well. Again, under careful supervision. You also want to be on the lookout, as this case nicely showed, for basilar invagination. Now, one of the important things to keep in mind is spinal rheumatoid arthritis typically does not calcify with that retrodental pannus. Whenever you see that calcified retrodental soft tissue, be thinking about calcium pyrophosphate dihydrate crystal deposition disease, or CPPD. It's not a completely predictive thing. There are times in which you can have coexistent CPPD and RA and therefore get some calcification, but in general, RA does not calcify and CPPD does. So this is a nice paper for the neurofellows and the residents to take a look at. This is sort of a nice review of those craniometric measurements. Something that I personally find to be a bit painful, but very important topic, something that all radiologists who interpret these type of images need to be familiar with. So definitely worth taking a look at. Okay, so let's wrap this up. The key imaging features to take home from this case of spinal rheumatoid arthritis: be on the lookout for erosions, particularly involving the dens, the uncovertebral joints, and the facet joints. Look for non-calcified retrodental pannus, potential atlantoaxial instability, and as this case nicely showed, basilar invagination. A couple of pitfalls to keep in mind: that calcified retrodental pannus should really sway you away from the diagnosis of rheumatoid arthritis and be thinking more of calcified retrodental pseudopannus in the setting of calcium pyrophosphate dihydrate crystal deposition disease, or CPPD. Now, that being said, you certainly can have, as we say, ticks and fleas, in which patients have both RA and CPPD. In that case, certainly it could be calcified. But in general, if you're looking at purely RA, much less common to have calcification than you are with CPPD. And then the most important take-home point: this atlantoaxial instability can kill or seriously injure your patient. So you don't want to overlook this finding, something that needs to be reported, because these patients may have their spine manipulated in terms of intubation or surgery. And in addition, these patients may be at high risk for significant injury even with mild trauma. So don't forget about that atlantoaxial instability. Well, as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thank you so much.